Welcome to the pneumothorax presentation. So this will be a shorter presentation, but there's going to be a lot to go through, so we'll see how it goes. So when we're looking at a pneumothorax, there are several things that can cause a pneumothorax. So one of them is a hole from the inside of the lung, like a hole developed from the inside of the lung that happened, and this can be a result of just like a blood popping or positive pressure ventilation, too much pressure or too much volume. There could be something like that going on that easily causes a hole to open up from the inside of the lung tissue itself. Another one would be a hole from the parietal pleura. So there's a puncture from the outside of the chest wall that goes into the pleural space. So that would cause a pneumothorax as well, because remember, there's negative pressure in your pleural space compared to atmospheric pressure. So when we put negative pressure space and atmospheric pressure is going to want to equalize, so it'll rush into the chest wall and cause that crushing of the lung tissue there. So there are two basic etiologies there, one from inside the tissue, one from outside the tissue, from like the chest wall, the parietal pleura there. So one's a rupture in the visceral, which would be inside or spontaneous pneumothorax. One's a hole in the parietal pleura, which would be a puncturing, like a puncturing chest wound type thing going on there. Understand there is a sort of third category here, and that category would include things like anaerobes that produce gas, and that could easily, if you have those anaerobes in your pleural space, they can produce that gas and actually cause a pneumothorax without a hole in either the visceral or the parietal pleura as well. Those are usually very small pneumothoraces. They're not something that you're going to see someone usually have a tension pneumothorax from. And when we're looking at pneumothorax, usually we want to look at, I know I'm getting ahead of myself a little bit here, but I want to get it sort of in your brain so you could keep it in the back of your mind during this. If we see that the pneumothorax is less than 20% on a chest x-ray or CT scan or an ultrasound, when we see that it's less than 20%, usually we won't treat it. In other words, we'll let the body resolve the pneumothorax on its own. So that means it's not really, as far as signs and symptoms, it might be uncomfortable. They might have some minor chest pain with it. But as long as it's less than 20%, it's not considered significant enough to treat. So they'll monitor them closely, but usually it's that 20% is that key rule that's out there about a pneumothorax. So once again, there's a whole, you can either have all in the visceral parietal or the parietal pleura. And then there's that third type too, where it can sort of just develop from anaerobes in the pleural space as well, like from an infection or something like that. There are different types of pneumothorax out there. Like I said, there's even something called a catamenial pneumothorax. Those are for people usually more common in endometriosis patients, and it actually correlates to their cycle. So it's kind of interesting where it can cause a weakening of the lung tissue itself, and then that can develop a pneumothorax too that occurs on a monthly cycle as well. So there's different types out there, but we'll focus on just primarily both the parietal and the visceral pneumothoraces in this presentation. All right, so this is chapter 23 in my book. So this is when gas accumulates in the pleural space. Now remember, there's a bunch of things that can accumulate in the pleural space. There's chyle, there's pus, there's, blood as a hemothorax, pleural effusion, which is fluid, whether it's transudative or exudative. There's a bunch of things that can develop in the pleural space, and this is just gas that accumulates in the pleural space. So this is just specifically gas accumulating in the pleural space. So when we're looking at the pneumothorax, we're looking at pneumothorax when sometimes they call it free air accumulates in the pleural space. So this is just that free gas accumulating in the pleural space. This will cause the visceral and the parietal pleura to separate. They're going to start to be pushed away from each other. Remember, the lungs are introverts, the rib cage is an extrovert. They always have that push-pull relationship, right, which creates that vacuum in the pleural space. So when we see this, the visceral and the parietal pleura will start to separate from each other. As they start to separate from each other, it's going to collapse the lung tissue, right? Because the lung tissue is going to go back to its introverted or collapsed state because now it doesn't have that suction it needs from the chest wall to stay open. So it's going to go back to its normal elastin state, that closed introverted state, right? And it's going to collapse the alveoli. We're going to have what's known as compression atelectasis. Sounds like a key thing to know about pneumothorax is it can cause compression atelectasis. Once again, compression atelectasis. Compression atelectasis. In severe cases, when it gets to where it squeezes, remember you have your superior and your inferior vena cava that feed venous blood from either your head, the top of your torso, or from your lower body. If you have a severe pneumothorax where all this gas pressure develops in the pleural space, it can crush the vena cava and restrict it from returning fluid back to the heart. So what do you think is going to happen with the blood flow through your heart and your lungs? What's going to happen with your blood pressure if we crush those great vessels, right? Your vena cavas. If we crush those vessels, those great vessels, because there's so much pressure in the thoracic cage now, then your cardiac output and your blood pressure are going to drop. You're going to have a decrease, a severe decrease in heart rate and blood pressure. Pretty bad. So when this happens, when this compression happens that we're seeing with all that extra pressure on the great vessels, right, the superior and inferior vena cava, that's when your venous return to the right heart diminishes, and this is what's called a tension pneumothorax. Now understand, a tension pneumothorax can happen either from a hole in the visceral pleura or the parietal pleura. Remember, this can be as a result of a stabbing, or this can be a result of just a spontaneous hole in the lung that occurs with too big of a breath, right? Or a cough, or something that back pressure the lungs. So this can happen from either an internal, also known as spontaneous, or from an external, like a traumatic pneumothorax. So when we have this and it causes vital sign changes, this is called a, I can hear you saying it in your brain, this is called a, don't let it make you too tense. Yeah, it's a tension pneumothorax. All right, so this is the picture from your book, right? Nice and pretty here. So when you're looking at this, this is a right lung that caused a tension pneumothorax. So what we see here, do you see the trachea deviating away from the pneumothorax? This is the mediastinal shift away, and I have some x-rays in this presentation to go through that with you, but you'll see that lung collapse, right? So a bunch of gas filled up in this pleural space, and it's crushing, causing compression atelectasis on the lung itself. So we're going to have that atelectasis. All that excess pressure is actually pushing the mediastinum away, right? That's that trachea mediastinal shift. Now remember, this mediastinal shift is still tested on the board exams. So they'll give you a scenario and you'll ask to assess the trachea or the mediastinum, and then they'll say it's deviated to the left. And if everything else is pointing to a pneumothorax, then you know that the pneumothorax is on the right because it gets pushed away. And I call this stranger danger. If it's outside the lungs, the mediastinum runs away. Stranger danger. If it's inside the lungs, like massive collapse of tissue, like let's say there's a massive tumor that develops inside the lungs, then the trachea mediastinum will go towards it. It becomes sympathetic to that area. So when it's away and it's in the pleural space, then the trachea runs away. All right. So you need to know which direction the mediastinum will shift. With a pneumothorax, it will shift to the opposite side. So the trachea is deviated to the left, then the pneumothorax would be on the right, and then the opposite, of course, is true. If the pneumothorax is on the left, the trachea would then deviate to the right, right? It runs away from the affected side. runs away from the affected side. So in this case, you're going to see alveolar collapse, right? You're going to see that compression atelectasis that develops. And with a traumatic, or sorry, a pneumothorax of this size, it will compress those great vessels, the superior and inferior vena cava. So there's going to be a backup of blood, but there's not going to be any ability to dump it into the right side of the heart. So you're going to see that dramatic drop in their blood pressure, right? If they're on a ventilator, and I know you guys don't need to know this yet, but if they're on a ventilator, their pressures, how much pressure it takes to give them a breath will increase pretty darn high. That's your peak inspiratory pressures. So you'll go into the room, you'll see hypotension, and you'll see their peak pressure is really, really high. That can be a sign of a pneumothorax. And we have a mnemonic, of course I love mnemonics, that looks at how to troubleshoot a patient with an artificial airway, and it's just called DOPE. Dislodgement, obstruction, pneumothorax, equipment. You don't need to know that for this class. For a critical care class, you will, so there's a little preview. So we try to see if the tube is dislodged. We try to see if there's an airway obstruction, like a massive mucus plug. Then we try to rule out a pneumothorax. And then if we've ruled out those things from being the issue, then we'll see if it's an equipment issue. Maybe we just need to change the ventilator or something like that up. So this is all optional information here. I do need you to know that the blood pressure would drop. It can cause a pretty massive drop if it's a tension pneumothorax. All right, so what are some anatomical alterations that occur with a pneumothorax? This is going to be restrictive because remember, the lung tissue, right? The lung tissue itself is being crushed, right? So the lung tissue is being restricted from moving. So this is a restrictive disorder altogether. So restrictive disorder all over. So the major structural change, lung collapse. Atelectasis, right? The lungs will collapse, that pushes them together, which causes atelectasis. The chest wall might actually expand, especially in a tension pneumothorax, because what happens, all this gas is just building up in this pleural space. So you might actually see a bigger AP diameter. In theory, you could see a bigger AP diameter on these patients because this pressure is building up on the inside of their chest. Gas can get in. Let's say there's a hole in their parietal pleura, right? Let's say there is a stabbing or a gunshot or something like that. There's a hole in their parietal pleura. Well, gas can then go into their lungs, right? Because now we've created that one-way valve for gas to be sucked into their pleural space. But when it goes in and it closes, right, because it created a one-way valve, it's not going to let that gas back out, right? So on inhalation, gas can go into their lungs, right? And then all this pressure built up on the inside of their lungs, right? This pressure is building up, that little flap then closes, and so it just continues to build up, right? So that gas pressure continues to increase. So this works as a one-way valve. And that's where it gets really, really bad. That pressure won't relieve itself unless we do something. If this continues on, compression of the great veins, right, your vena cavas, your superior and inferior vena cavas, can decrease your cardiac and venous return. So what would you see with the heart rate, right? Remember, cardiac output equals stroke volume times heart rate. Okay, so if we don't have this stroke volume, if we are not supplying the heart with volume, what's going to happen to your heart rate to compensate for your cardiac output? Is it going to go faster or slower? Well, mathematically, right, if our stroke volume decreases, the only way to keep a good cardiac output would be for the heart rate to compensate and increase. So you would see a pretty significant tachycardia. And I hope this makes sense to you a little bit, but we'll get to it here soon. So lung collapse, which causes atelectasis, chest wall expansion of so bigger AP diameter, and then compression of the great veins could cause a tension pneumothorax, right? And you'd see that hypotension and high heart rate. So remember we talked about different types of pneumothorax. So you can get entrance into the pleural space from the lungs through the visceral pleura, right? Remember the visceral is the one that surrounds the lung tissue itself. So that would be AKA spontaneous. We call them spont pneumos or spontaneous pneumos. That means if I cough too hard, or if I'm a tall, thin individual, which I'm not, but I'm a tall, thin individual, I might not have a lot of space. I might have a hyperexpansion in my apices, and coughing or exercising or something like that could, in theory, induce a spontaneous pneumothorax. Babies, especially newborns, where their rib cage is not really set, right? Their rib cage is very malleable. They're a lot more prone to a spontaneous or a pneumothorax or a perforation in the visceral pleura, right? The second way is from the surrounding atmosphere through perforation of the chest wall, through the parietal pleura, right? This could either happen through there, like a stab wound or gunshot or something like that, something that perforates. That a nail gun, right? You work at a trauma center, you'll see a lot of different things. And it can also happen through an esophageal fistula too. That was a rare case. You could also see it happen through the abdominal cavity as well, something that perforates that parietal pleura. So it's not always necessarily a trauma. Sometimes it is also through something like the abdomen or esophagus or something like that. So just keep that in mind, in the back of your mind there. If they have a lot of esophageal fistulas, that could actually be a source of that as well. And then the third type is from gas-forming microorganisms, like an empyema. Little pus in there. This is a lot more rare. Usually it's an infection situation that's going on here. You can either have a closed or an open pneumothorax, right? Depends on the way the gas went in there. So closed pneumothorax would be this, number one, right? That's where it happened from inside the lung, right? That's where it happened from the visceral or lung surface itself. Someone took too deep of a breath, popped a hole in their lung tissue. That's a closed pneumothorax. Now, an open pneumothorax would be gas getting entrance through the pleural space, right? So you have your lung tissue, and there's a hole that develops, and then now gas is going into the pleural space. This would be your open pneumothorax. And then your closed pneumothorax would be a hole in the visceral pleura. So this would be closed. So when you're looking at this, that's just where the etiology of the pneumothorax. Did it happen from the lung tissue or did it happen from the chest wall? Right. Either way, you're going to have a bunch of gas developing in that pleural space. But is it an open or a closed pneumothorax? So closed, the pleural space has no communication with the atmosphere, right? We just have gas escaping from inside the lung to inside the pleural space here, right? With an open, this pleural space is communicating with the atmosphere, and that's why we see that. We have positive pressure in the atmosphere, negative pressure in the pleural space, not for long, but that's what the relationship usually is, and that's what will happen there. Now, the tension pneumothorax, right, this doesn't indicate closed or open, right? Either one of these, closed or open, can cause a tension pneumothorax. I'll say that again. Either one of these, a closed or an open pneumothorax, can cause a tension pneumothorax. This is where it gets to the point that your pleural pressure is greater than alveolar pressure, which then causes compression of your great veins, which then causes tension on the heart and the lungs, and you're going to see a change in blood pressure, a change in heart rates, usually a change in saturation. So a tension pneumothorax can be from a closed or an open, right? It's not really a type, it's just indicating the severity of the pneumothorax. How severe is it? Well, it's severe enough that the pleural pressure is greater than alveolar pressure. It doesn't indicate etiology, it doesn't indicate what caused it, it just indicates that it's severe enough that my pleural pressure exceeds alveolar pressure. Hopefully you get this point. All right, so open or traumatic pneumothorax, usually this is gas in communication with the atmosphere. So as we're looking at the lungs, right, there's a dramatic hole. It's in communication with the atmosphere. It's supposed to be pressure atmospheric. So when we're looking at this, usually this is known as a sucking chest wound as well, because remember, there's negative pressure in the pleural space and atmospheric pressure is positive. So you're creating a vacuum to get gas from outside in the atmosphere to inside in the pleural space. So that's why it's called a sucking. It'll suck atmospheric gas into there. Not because it's not going to be a fun day for that patient, right? That's a whole different type of thing. Knife, bullet, any impaling object can be used. I've seen rebar from construction accidents. You'll see a whole bunch of different things, especially if you choose to work trauma, especially at a level 1 trauma center. So you'll see different types of things out there. Sucking chest wound, open pneumothorax, right? It could be a number of different things. It's usually a result of trauma. So it can also be a result of a valvular or tension pneumothorax, one-way valve in the parietal pleura. So we're still having a tension pneumothorax would be, so let's say we have a puncture in the chest wall. I need more drawing space here. So we have a puncture in the chest wall, and it creates that one-way valve like I was drawing in there earlier. So that one-way valve means gas can get in, but it's not going to let it back out. It's just going to accumulate in that pleural space, right? It's not going to have the relief to get out. And so when this happens, this can result in a closed pneumothorax where we're going to have a bunch of pressure built up in that pleural space, and it's not going to be able to get out, right? And so if whatever punctures the rib cage or punctures that parietal pleura causes a one-way valve effect, which it can, because remember it's going from the outside in, if it causes that one-way flap, then that builds up a ton of pressure. Now let's say it's just a gaping hole and there's no one-way valve that was created. Well, now you're just going to have equilibrium because now gas can both get into the pleural space and get out of the pleural space. Is that better? No. But not by any means. But this is just saying it can create a one-way valve, and that's not good. And that's what it's talking about there. So a lot of them can create a one-way valve. Others, it's just a hole that does not create a one-way valve in the parietal pleura, and then that's still not good because then you have equilibrium, which means you still cannot expand that lung tissue because you need that suction to expand that lung, right? So if you have that one-way valve, it can't leave, and this acts as a one-way valve, and then it's just going to end up building up more pressure and more pressure and more pressure, right? That's where you might see an increase in their AP diameter. Now let's just say it was just a gaping wound that did not create a one-way valve, right? So if it's just a gaping wound, then you may not see an increase in their AP diameter. Their AP diameter might just stay normal here because there's not that buildup necessarily of pressure. We've just reached equilibrium. I hope that makes sense to you. So a lot of these can create a one-way valve effect. Some of them may not. It's just paying attention to what's going on with your patient. If it does create this one-way valve effect, it is more serious than the one that's the gaping wound, right, with no one-way valve. So this is a pneumothorax that's the most serious of all. I would highlight and star this, and notice this is in bold. So this is the most serious form of all when it creates that one-way valve, because that gas will continue to accumulate. When it does this, instead of just reaching equilibrium, right, remember this one would have an increase in your AP diameter and have a greater chance at compressing your great vessels and causing a tension pneumothorax, right? So that's one of your big things. This person can go into demise very quickly. So just pay very attention. If their AP diameter is increasing, right, this could be a sucking pneumothorax that developed a one-way valve, and then that could then cause a rapid demise of this patient if we don't relieve that pressure soon, right? And we'll talk about different ways to relieve that pressure. Okay, so these are pictures that I took from your book. And this is looking at pendulift or external pneumothorax, one that has a open where it does not create a one-way valve. So there's no one-way valve up in this top right picture. And then down here is where it creates a one-way valve in the bottom left-hand picture. So let's look at the top right first. So this is an open pneumothorax or traumatic pneumothorax where it's compressing. You see how the gas is flowing in and building up pressure in that pleural space, right? So as the person inhales, they're sucking gas from the atmosphere into that pleural space. That pleural space is then building up pressure and crushing that lung. Notice that we have gas that they're inhaling is actually being shunted or sent over to the opposite side. Well, that's because this lung over here on the right side, this one over here on the right side is being compressed. Gas always flows the path of least resistance. So the path of least resistance, you got a bunch of collapsed lung tissue over here, right? Collapsed lung tissue, and over here you got a bunch of tissue that's already open, right? So there's a lot less pressure needed to open those areas, so the gas will flow to that open area already. So if you're thinking, hey, this person has an open pneumothorax and it's collapsing their lung tissue, let's just increase the amount of pressure we're giving them to help re-expand that lung. Well, that's not going to work, because all you're going to do is hyperinflate the opposite side and actually cause a higher chance of developing a closed pneumothorax on that opposite side instead of reopening that closed little side. So the fix is not give them more pressure, okay? So as the patient inhales, gas will go in. There's that movement of gas flow to the opposite lung. And as they exhale, right, as you see these arrows point up and out, as they exhale, the gas will flow out. Some of the gas pressure inside that pleural space will relieve itself, right? Remember, we're at equilibrium. We got a little bit of positive pressure. The rib cage is moving inward during exhalation, right? It's moving inward during exhalation, and so that should help squeeze some of that pleural space gas out. So this person is not building up near as much pressure in the thoracic cage as someone with a one-way valve effect that you see down here on your bottom left. So let's move down to the bottom left. So on inhalation, when you're looking at this patient, gas is being sucked in from the atmosphere into that pleural space. It's crushing that right lung. The mediastinal will shift to the left side. Gas is flowing, of course, to the opposite lung, right? Do not fix this with adding more pressure to breathing. That can cause even worse issues. All right, so as the patient goes into exhalation, whatever punctured them caused that one-way valve. So this valve closes, and that means gas pressure does not get relieved. It does not come back out with the rib cage moving in. So that means there's a buildup of even more pressure in here. And it's going to build up even faster at a greater effect than if it was just an open, completely open during all cycle pneumothorax. So this one-way valve, remember, is the most serious. That open valve pneumothorax, that tension pneumothorax, they have a higher chance of that tension pneumothorax with this one-way valve effect. So it's pretty darn serious when we're looking at that bottom left picture, and hopefully this sort of makes the difference for you. One is trapping way more gas than the other, therefore has a greater chance at compression of vessels, greater chance at demise ultimately. All right, so spontaneous pneumothorax, this is a different type, right? We just talked about open pneumothoraces. Now we'll talk about closed pneumothoraces, right? These are ones that happen in the visceral pleura, right? So if we're looking at the lung tissue, these are ones that happen in the pleura in the tissue or the pleura that surround the lining of the lung itself, not the rib cage, but the lung itself. So this is from a deep cough, right? Tall, thin individuals, usually in that young adults range, that 15 to 35, can have these spontaneously, and usually these happen in the apical areas. Because remember, in the apices, remember these areas. When your rib cage moves during breathing, it's mostly the lower, your bases, that move more than your apices during your breathing, right? You can test this yourself. So go lay down on a flat surface, right? Like the floor or something like that, and then feel the base of your ribs move out, right? Take a deep thoracic breath, right? Don't do the abdominal breathing, but take a big chest breath, right? And feel the bases of your lungs, your base of your rib cage move out, right? Now do the same thing, same depth of breathing, but now feel the apices, like right under your collarbones or right in that area, and then you're going to see that the rib cage and your apices hardly move at all compared to your bases. And so when you're looking at these individuals, their apices are almost open all the time, right? We talked about that in pulmonary MP, where your apices almost hardly move at all in the respiratory zone because there's more suction, right? There's more room here that creates negative pressure, so they stay open more than your bases, which have a lot less room in that area, which is the part that expands the most. So these areas, according to Hooke's law, remember Hooke's law says that I have increased expansion for every one pressure until I get a point of almost popping a bubble, and then it's going to take a lot of pressure, right, to get those places expanded, right? I reach the point of stretch, maximum stretch. It's like blowing up a balloon, and it's about ready to pop. It's going to take even more pressure just to get it to expand one little bit. So these people, their balloons are expanded very, very far because they're so tall, and because there's not much mass that's causing any collapse. So these tall, thin individuals have this Hooke's law in effect in their apices pretty much all the time. So this means if they take a really, really deep breath, they can hyperexpand this to the point where it ruptures and causes that spontaneous pneumothorax. So it's more common in their apices, of course, and that's where you'd see it. Now, does it mean it's going to cause a tension? No, it actually rarely causes a tension pneumothorax. They would usually have chest pain, things like that. And usually it's a less than 20% pneumothorax as well. But hopefully you sort of see that tall, thin, pathophysiology, right? You see that it's more common in the apices because there's greater negative pressure, and Hooke's law is in effect. It says, hey, you're almost to the breaking point, so a really, really deep breath could actually cause it to go over that breaking point. So tall, thin individuals can cause a spontaneous pneumothorax. High negative pleural pressure is generated up there. That's what we're talking about. Takes stress most commonly in the right upper lobe is what we're looking at here. You can also have a spont pneumo. Now this is just separate, right? You can also have a spont pneumo secondary to other diseases like pneumonia, tuberculosis, or COPD, right? What's happening to the lung tissue? Is the lung tissue extremely healthy in these individuals with pneumonia, tuberculosis, or COPD? Absolutely not. Lung tissue is very, very weak, which means it's more prone to rupture, right? And that's what we're looking at. So especially in COPD or emphysema, they can develop those blebs or bullae. And I remember those, the COPD and the emphysema PowerPoint. I think I showed you some actual pictures of blebs and bullae, right? Those are those things that look like aneurysms, like, you know, right? You have your aneurysm of your aorta, right? That outpooching, that weakening of the wall. So the same thing that happens with like an abdominal aortic aneurysm where that can rupture. Same thing in your lung tissue. You can develop those little aneurysms or blebs or bullae when they're in the lung tissue, and those can rupture and cause a spont pneumo as well. So you might see this with someone that has severe emphysema. They might cough or develop a pneumonia, and then they might cough as a result of their pneumonia and then develop a hole in one of their blebs or bullae. They might rupture. So this would be your spontaneous pneumothorax, right? So this is showing a right-sided pneumothorax. This is a rupture in the visceral pleura, right? This is a rupture from inside. Okay, so let's talk about a different type of thing that can cause a pneumothorax. These are iatrogenic pneumothoraces. So iatrogenic is we're looking at sort of healthcare-induced pneumothorax. So this is where something we did, right? There was some sort of diagnostic procedure that we did that led to the development of that pneumothorax when we're looking at this. So a good one of the things that could happen is usually during a biopsy, these patients can develop a pneumothorax, especially when it's really close to the lung tissue. So usually this is a hole in the parietal pleura, right, the outside the rib cage pleura, when we're looking at this type of pneumothorax. So liver biopsy, right, we're right next to the thoracic cage. A thoracic needle biopsy. A thoracentesis, so let's say someone has a massive pleural effusion and we go to put in a needle into their pleura, we could even cause a pneumothorax there. Intercostal nerve blocks, CVP. So this is where a central venous line, especially when it goes to the subclavian. So there's two general ideas here. You can do the subclavian, here's the sternal notch, here's the sternum, and then the subclavian vein runs right beneath the the clavicle. And so when they do this, they have to insert the needle into that area sort of right behind, it's a blind stick, they have to insert the needle right behind the clavicle and try to float the catheter that way. They can use ultrasound to help guide it, but when they do this, what's right behind your clavicles and your sternum and your rib cage, right? What is behind there, right? Lung tissue. So there's a chance that when they're trying to introduce this this line into and float it into the subclavian vein, that they can actually rupture lung tissue, right? And that's one of the indications for X-ray is actually post-line placement to make sure that they didn't cause a pneumothorax, an iatrogenic pneumothorax when we're looking at this. These can also happen as a result of a tracheostomy, of course, like once again, needles being placed in the rib cage, thoracic cage, trachea, all that stuff. Hey, what's this last one? Oh yes, positive pressure ventilation. That's us, right? Usually this is us using too much pressure or barotrauma, right? Too much pressure. And so that's why we try to keep what's called plateau pressures low. We try to keep them less than 30 centimeters of water pressure. Why 30 centimeters of water pressure? So when we're looking at a ventilator, peak inspiratory pressure, and I'm just going to give you this little preview, you won't be responsible for this on your test. When peak inspiratory pressures can rise as a result of airway resistance, right? So let's say you're having a bronchospasm and all the tissue in the lungs getting narrow, right? It's getting bronchospasmed and narrow. So when you have that going on, it's going to take a lot more pressure to get to the respiratory zone. So that would cause an increase in your peak pressure. But because by the time that gas gets to the respiratory zone, a lot of that pressure has been dissipated, you may not have an issue where the respiratory zone has too much pressure on it. So I've had patients where their peak inspiratory pressure has been 50 and their respiratory zone is just fine because there was so much, it took so much pressure to get through the conducting airways just to get there. And by the time the gas gets there, it's lost almost all of its pressure to expand their lung tissue. So the peak pressure is not a good indicator of how much stress there is on the respiratory zone. So what's the most sensitive part of the lung tissue? Well, it's conducting airways or the respiratory zone. Well, it's going to be the respiratory zone every day. And so I want to see how much pressure is being put on the respiratory zone, and that's where the plateau pressure, not your peak pressure, comes in. I want to keep the pressure on the alveoli less than 30 centimeters of water pressure, right? So this is the area here where when we touch the ventilator, we press what's called an inspiratory pause, and it's going to stop the ventilator from cycling into exhalation. And when this does this, it's going to see how much pressure there is specifically on the respiratory zone. I want that pressure, when it's doing that measurement, to be less than 30, right? Less than 30 means we're being lung protective. We're not over expanding. We're not putting too much pressure on the respiratory zone, right? So there's a difference. Peak pressure may not equate to respiratory zone. Plateau pressure does equate to the respiratory zone. Therefore, I'm going to look at plateau pressures as being friendly if they're less than 30. If they're over 30, that's a sign they're very unfriendly, and now we have an increased chance for not only alveolar destruction, but now we have an increased chance for a pneumothorax. Hopefully this makes sense. So positive pressure ventilation, we need to make sure that pressure is less than 30 centimeters of water pressure. All right, so what makes someone at a risk for developing a pneumothorax? Well, trauma is going to be a big thing, and that includes both open and a closed pneumothorax. So let's say you are driving along and a vehicle decides to run a stop sign or a stoplight and decides it's about to T-bone you. You see the car and it's about to T-bone you, right? This is a very graphic visualization. I hope it doesn't hurt you guys. But so what are you going to do? Are you going to let your breath out and relax? Or are you going to take a deep breath in and hold it, brace yourself, right? Odds are when most people do this, when people are involved in a car accident, they might not have a open pneumothorax where some metal punctures the rib cage. They most likely have it because they took a deep breath, they held their breath, so the lung tissue was expanded, and now they caused, when the body was compressed, when their body was compressed or hit, it caused so much back pressure in their alveoli that it actually caused a closed pneumothorax, right? That's where the back pressure that they use, because they brace, they close their glottis and they back pressure their chest wall. That's that squeezing, that Valsalva type maneuver, right? They back pressured, and that can actually cause a pneumothorax from the inside. So because even though you don't see any puncture wounds on their rib cage, for even, like I said, a car accident victim or a trauma victim, they could still have a pneumothorax because of this bracing, because of that sort of fight or flight freeze situation going on. They froze, they took that deep breath, they did that Valsalva maneuver, and then it back pressured to the point where it caused a spot pneumo, right? So just be aware of trauma victims. Even if you don't see a puncture wound, you can easily still have a pneumothorax. I hope that makes sense to you. I'm just trying to prepare you guys for what you may see in the future, right? Just because you don't see any holes in their chest doesn't mean they don't have a pneumothorax, especially when you're going through your dope mnemonic, right? Sometimes you have pneumothorax that develops without any underlying cause, like the tall, thin individuals. We already talked about that. Sometimes it's secondary to another disease process, like pneumonia, tuberculosis, COPD, right? And sometimes it happens because we did a procedure ourselves, whether it's diagnostic with with putting in a line to look at cardiac pressure. So like when we're putting in the Swan-Ganz to look at the heart pressures, systemic vascular resistance, wedge pressure, cardiac output, pulmonary vascular resistance. Like, we're looking at all those things with the Swan-Ganz catheter, but to put that in, we have to put it in through a central line, which that diagnostic indication, by doing that diagnostic procedure, could cause a pneumothorax. Or it could be the result of a therapeutic procedure like a mechanical ventilator, right? Too much plateau pressure, we let that plateau pressure build up on that patient. We use too much pressure or volume to ventilate, right? And we expand that alveoli a little too much, right? That plateau pressure is a little bit too high, right? It's greater than 30. I'd remember that number, by the way. Greater than 30, and then that caused that hole in the alveoli, right? So it could be secondary to diagnostic testing and or therapeutic procedures that we do with the patient. So that's one reason why we'll get a lot of x-rays in the hospital. Hey, you got a central line? You're going to get an x-ray. Hey, we're on mechanical ventilation? Let's get an x-ray, right? Things like that. Okay, so patient has a pneumothorax. What are they going to look like at the bedside? Well, of course, this is restrictive, which restrictive pathology means you cannot take a deep breath, right? You're restricting. It's like someone bear hugging your chest, right? They're squeezing you super tight. And so your ability to expand your rib cage, to expand your lungs, is impeded in a restrictive process. In this case, it's your inability to expand your lungs, not necessarily your chest wall. And so if you can't breathe deep, then you got to breathe fast, right? So they'll be tachypnic. This is where we talked about mediastinal shift. Now, Pendeluft, what the heck is that? Pendeluft is a German word, and that's, remember when we were looking at those pictures where gas was flowing to the right side of the lung when we had, to the left side of the lung when we had a massive pneumothorax on the right side? So when we had that massive pneumothorax on the right side, gas was flowing to the opposite lung. Well, that's that shunting of gas from one lung to the other. So when we have gas movement, instead of gas moving in and out, right? So just a linear relationship where gas either flows in and flows out. When someone has a mediastinal shift or a significant pneumothorax greater than 20%, when they have that mediastinal shift, it can create a cross-washing. So in other words, instead of the gas going in or out, like what we see here, so up and down, in or out, right? Instead of that gas going in or out, it moves from the right lung to the left lung. So it's a crosswash. It goes back and forth. Some of it may go up and out. But instead of it going up and out, some of them gets caught in that movement of back and forth between the right lung, left lung, right lung, left lung, right lung, left lung. And so this is called Pendeluft, like a pendulum swinging back and forth, right? Instead of going up and out, it goes back and forth. What does this mean? Well, if you have CO2 that's coming through with blood flow, are you going to get rid of CO2 very easily if you have Pendeluft? No, you won't. And so this means that your CO2 levels are going to go up, right? So Pendeluft, if you see a mediastinal shift, that's where you got to be aware of Pendeluft, right? That's where you got to be aware that they might have that crosswash. They might have a hypercarbia building up, which hypercarbia will then cause you to breathe faster because you're going to be more hypoxic because the hemoglobin are going to be carrying CO2 more than oxygen, and so it's a massive cycle of craziness here. Obviously, pain and anxiety, especially. I can't breathe, I'm in a lot of pain, something punctured my chest wall, or massive chest pain from the inside. Tachycardia, we already talked about this with your stroke volume times heart rate. Also a result of cyanosis that can cause tachycardia as well. So the heart's going to be working overtime here. Hyperresonant drum-like percussion note. That's why I put the picture of the drum in there, right? That drum-like, if you're to do diagnostic percussion of the pneumothorax. And I had this happen at the bedside. I had a patient on a ventilator develop a pneumothorax, and then a therapist right next to me, she went ahead and did diagnostic percussion, and it was that deep, hollow sound, like a drum-like sound that you would hear. And it was one of the only times that I've actually ever heard the diagnostic percussion actually come in handy. So there is times where it can come in handy. Don't think it's not handy. Tracheal shift, remember it goes away from the affected side in a tension pneumothorax. It runs away, stranger danger. Displacement of the heart sounds, the PMI can shift. Now remember, the point of maximal intensity for your heart is supposed to be between like the 4th and 5th intercostal mid-clavicular on that left side. So if it shifts, if it gets pushed over to the left, in other words, it's closer to mid-axillary where the heart sounds the loudest, then that actually might be because the right side is being pushed over so much that it pushed that over even more towards the left. Now let's say your PMI, instead of being 4th, 5th intercostal space mid-clavicular on your left side, is now closer to where it's sternum. Then there might be a massive pneumothorax on your left side that's pushing the heart over. And I hope that makes sense. So that's where the PMI can come into place in listening for the heart sounds. You're not listening for if there's a murmur, rub, or gallop or anything like that. You're listening for where it's the loudest. And sometimes telling where it's the loudest might actually be very telling if there's a pneumothorax present, if you can't get an x-ray right away or anything like that. Like I said, this is more of a bedside thing. An x-ray is going to be more helpful than this. But if you're at the bedside, it's one of those things you can do right away besides diagnostic percussion that might be able to help you there. Increase in thoracic volume on the affected side. We talked about the AP diameter increasing, especially if there's a check valve, right? So the AP diameter might absolutely increase, especially if there's a one-way valve effect in place, right? And those one-way valves are a high chance of making a tension pneumothorax, so that tells you this is a very serious case if you do see that hyper expansion of the rib cage on one side versus the other. Okay, so this x-ray is just trying to highlight that mediastinal shift. So over here we have a pneumothorax on the left picture, and you notice that they outline the trachea for you in those white dotted lines, and so you see sort of the collapse of lung tissue here, right? Just sort of that collapse of tissue, and so that pushes everything over, and you can even see the heart being squished, right? You can see the heart being squished and being pushed over. So if you were to listen for the point of maximal intensity on this patient, instead of being mid-clavicular, right, fourth, fifth, intercostal space, now it's going to be moved over and it's going to be closer axillary, right? So that's why you would hear that PMI shift. Now over here, you'd also see their trachea main stem, right? You see that with these dotted lines. Just shift over. That's that mediastinal or tracheal deviation, right, that you would see. So if you were in theory to look at this patient, they come into the ER, low blood pressure, high heart rate, low oxygen levels, and you see their trachea shifted to one side, and you do diagnostic percussion, it sounds like a drum on their right side, and you see the trachea to the left side, you would think that it's more likely a right-sided pneumothorax, like what you see in this picture on your left. Over here, we see a hemothorax, right? All this is just fluid that's built up, right? Blood or fluid that's built up like a pleural effusion, and it's crushed that right side, that right lung, right? Here's your right lung up here in that apice right by the collarbone there, and everything's just crushed, and that's actually pushing the mediastinum away. So anything that happens in the pleural space will push the mediastinum, it will push the trachea away, and hopefully you see that, right? Everything's being pushed away from the affected side. So on this patient, we have a dull percussion note, right? Because there's fluid on the patient on the right. That dull percussion note, and then you see the trachea is deviated to the left side. Then you'd think that hemithorax or hemothorax, sorry, it would be on the right side. And you can see also atelectasis, a ton of atelectasis going on here as well. But just so you can sort of outline and see that tracheal deviation. Once again, the board exams will ask you about that, so it's something that you need to remember. So x-rays, we already just covered that one, but you're going to see translucency, right, on the side of the pneumothorax where it's darker. Because remember, there's a bunch of gas or free air in there. The mediastinal shift go to the unaffected side, right, in a tension pneumothorax. Now, it might stay neutral if you have like a little 10% pneumothorax. Let's say you're a tall, thin individual, has that spot pneumo, it might not move at all, right, because it's a very small pneumothorax. So it's usually involved with the tension that you see that mediastinal shift. The diaphragm on the affected side will be depressed, right? You'll see that excessive inflation of the pleural space on the affected side, like the right side with the pneumothorax there. You'll see a lower flattened depressed diaphragm. Your CP angle is going to be a lot flatter. Obviously, you'll see a lot of lung collapse and atelectasis that go along with it as well. Okay, so here is yet another picture of a pneumothorax, and this pneumothorax is so severe that it not only did it push the mediastinum over to the left side, but you could still even see the border of the right lung into the left space of the thoracic cage. That's how significant this pneumothorax is, right? Here you see the CP angle a lot flatter, right? Remember, you want to see a good arch here, like a McDonald's arch. Here you just see this sort of flat CP angle that's going on there. So that's a depressed or flattened diaphragm. And you see how radiolucent or how dark that right lung is compared to especially all this collapsed tissue, this atelectasis on the left side. So tension pneumothorax clearly here. Mediastinal shift to the unaffected side. So, and then you just see how big and massive that right-sided pneumothorax is in this x-ray. So hopefully these x-rays are helpful. Okay, so here's yet another one. I believe this one is from your book. So this is a small tension pneumothorax in the lower part of the right lung where you see the arrow. So on the picture on your left, you're looking down into that area, and you see it sort of highlighted. The arrow is pointing directly at it, and that's just that small And this would be just a insignificant, less than 20% pneumothorax. And then when you look at X-ray B on the right, this is the same pneumothorax 30 minutes later. And then notice that you see the mediastinum shift, and you can sort of see it. Let me see if I can highlight it for you if you don't already see it. Right, do you guys see this? Hopefully you can see that. And so you can even see the same pneumothorax just 30 minutes later, and you can see the outline of the lung tissue here on the right side. So let me highlight that for you. All right, I'm hopefully getting better at this. So you can see how much that pneumothorax just developed in a short span of 30 minutes, right? The shift of the heart moved over, right? Notice that the heart moved over in the X-ray too, between A and B. So you see the heart, so therefore your PMI would go towards the left, right? Instead of midclavicular on the left side in the 4th and 5th intercostal area, now it'd be more towards the mid-axillary, right? It'd shift, right? And they would move away from the tension pneumothorax, right? They would run away. The mediastinum all shifted away. The heart sound shifted away. And you see the diaphragm down here in X-ray B, you see the diaphragm just get even more depressed, more flattened out. So instead of that nice McDonald's arch, you'd want to see you have this sort of flat hyperinflated area here. So pretty significant. This is definitely the development of a tension pneumothorax. Now notice that this person has a central line. I'll try to highlight it here. Should have used a different color. They have a central line, and they're also on positive pressure, it looks like here. So there's a lot going on with this individual. If they're on a ventilator and they have a pneumothorax that's not treated, in other words, we don't have a chest tube or something like that in place to relieve that pneumothorax, it can develop into an exponential pneumothorax. Now let's say you work flights. You're a flight therapist and you have a pneumothorax on a patient because of pressure and volume varying inversely. What will happen to this pneumothorax if it's not treated? What will happen to this pneumothorax as you go up in an unpressurized helicopter? So if barometric pressure is decreasing, pressure decreases, volume increases, therefore the pneumothorax will get bigger, right? So if you're working flights and there's a possibility of a pneumothorax, you might want to treat that before you get up into the air. I'm just saying. So just a little side note. All right, so this is another one. I believe this is also directly from your book as well. This is a 19-year-old guy that's 6'5", and experienced a left-sided spont pneumo, right? Tall, thin individual after playing golf, right? Nothing traumatic, at least I hope not. It's not uncommon for these tall, thin individuals to get spont pneumos here and there, and this happened in his left upper lobe. So 45 minutes later, this patient's in an emergency room. The heart shifted, so the PMI would shift to the right, right? And you see the heart is pretty much almost midline, if not to the right side of the lungs. So it's a pretty significant shift towards the unaffected side, right? Away from the tension, right? Away from the tension. It goes the path of least resistance. And then you also see that the diaphragm on his left side is just flat, right? You see that depressed or flat diaphragm, right? No McDonald's arch here, which I don't think they even have arches anymore, but right, you remember your CP angle needs to be that nice arch, and this is just a flat linear angle there that's going on. And then the arrows are just pointing to the outline of the lung tissue here. So just be aware that they can get worse. They might develop. This is more than a 20% pneumo, so they might needle or put a chest tube into this guy, needle decompression or put a chest tube into this guy. I'm not sure what they did here, but more than 20% they're going to treat it, especially with this situation. Okay, so what do you think this is? I see something in here, right? All right, apices. Man, it's really dark on this patient's right side compared to the left side if we're looking at the apices. Bases, oh, my diaphragm is not very curved, right? I have a little bit of a CP angle, but it's not curved very much, especially compared to the arch on my left side. So if you were in the B of your A, B, C, D, A through I technique, right, of x-rays, you can see one area we have a pretty significant arch. The other area, it's more that linear, so depressed or flattened diaphragm. That's not great. ABC, cardiac. Right. Cardiac, not too big there. ABC. D, we already went over D. We have hyperexpansion on that right side. E, nothing's in his esophagus. F is for fissures. I don't see any of those. G is gastric. I don't see any gastric issues. H, hilar. Not too much hilar stuff going on. I, interstitium. Oh yeah. What do I notice here? Oh heavens. This is the outline of the patient's right lung that I just drew. This guy here. So that means this whole area on this individual over here that's in this space, that's pneumothorax. Notice what else do you see here? Do you guys see this? And I'll try to use, maybe purple will work for this. You guys see this radio-opaque line here? So this individual has a central line that's going subclavian. So and the pneumothorax is on the right side. So we have a pneumothorax on this patient's right side, and we have a central line on the right side. Well, this is a possibility. This could be an iatrogenic pneumothorax. So you'll have this happen where you'll intubate, put a patient on a ventilator, and then they'll put in a central line. An IJs, in theory, could do it where they put it through the jugular instead of the subclavian. They'll put in a central line, and that could cause a pneumothorax, especially while they're on the ventilator. So you might have to put in a chest tube on this individual as well. So just something to be aware of. So this would be an example of an iatrogenic pneumothorax. All right, so PFTs. Now, let's say you have someone short of breath, tachycardic, tachypnic, cyanotic. Are you going to be doing a PFT on them in the emergency room? No. And in fact, this is actually slightly more post pneumothorax than it is during the actual pneumothorax pathology. So in other words, your pneumothorax has been resolved, and they want to see how your lung function's doing after you're over the pneumothorax. So this is where this would come into place, right? Not someone that's tachypnic, short of breath, and they're ER, right? That has an active pneumothorax. And in fact, American Thoracic Society, so ATS, remember they're the people that do all the PFT stuff. The ATS says that an untreated pneumothorax is actually a contraindication for pulmonary function testing, because remember, you're changing the volumes and pressures in your lungs, and that could actually make it worse. So PFTs are post resolving all that stuff, right? So if you were to do a PFT on this individual, their post, they still might have residual atelectasis left over, or their pneumothorax is less than 20%, right? It's still left over, so they might still have collapsed lung tissue. So what do you think is going to happen with their volumes and flow rates? Well, if their tissue is collapsed, that means they're going to have low volumes, right? This is not good at drawing with this thing. So they're going to have low volumes, right? Tidal volume, IRV, ERV, all of these, low. But their flow rates, sorry, that's the one I was looking at. Their flow rates are going to be normal. Their normal flow. Low volumes, right? That's what I want you to get from this, because that's usually that residual atelectasis is left over, and they just want to see, okay, how bad was that pneumo residually? Residually, I want to see how much of their atelectasis has been resolved. We would see that with their volumes. Their flow rate should be normal. Hopefully. All right, ABGs on these individuals. So someone comes in, extremely short of breath, tachycardic, tachypnic, cyanotic. Do you think that's an indication for an ABG? Absolutely, right? If it's a very small pneumothorax, we might see an alkalosis, right? Remember, that's that cyanosis causing tachypnea and all that stuff with hypoxemia, right? So this is a normal, just like every other blood gas we've talked about. Respiratory alkalosis is going to be your mild case or a small pneumothorax. If it is very large, that's why there's a picture of a dinosaur. I know it's a pterodactyl, but they fly in the air, so I thought it was more appropriate than like a Tyrannosaurus, right? So we see a large pneumothorax. This is where you're going to get into a respiratory acidosis, right, with a lot of hypoxemia here. So obviously at this point they're unable to exchange gas. And then if they're really hypoxic, you might see a mixed or a combined acidosis. So for the purposes, just remember acute respiratory acidosis for a large, a small alkalosis, just like we have with the other ones. Nothing's really changed there. Oxygenation. So what happens with their oxygenation? Well, this is a shunt-like pathophysiology because we have perfusion without ventilation, right? Because remember, we have all this atelectasis, we have this compressed atelectasis, we have this consolidated, condensed tissue, right? That this tissue that's dense and closed up. And so is there ability to communicate gas in between the alveoli and the capillary? No. Capillary is doing just fine, so this is a shunting issue. We have blood flowing that's not picking up oxygen and getting rid of CO2. So this is a shunt-like process therapeutically. Their DO2, of course, is going to be decreased because their CCO2 is decreased. Therefore, their CaO2 is going to be decreased, right? Remember this? So the CO2 is downstream of the CCO2. Your capillary content is going to be very, very low because of the shunt-like process, because of the collapse. That means your CaO2, or how much oxygen is getting into your bloodstream, is decreased. So therefore, their DO2 will be low. Their metabolic rate, so their VO2 and A to V ratio, normal, right? In a severe case, it can be really, really high with their A to V gradient. Now, this is where you're looking at anaerobic metabolism at the tissue level. Remember, we have these all drawings. If you get to the point where the DO2 is low enough, you can cause anaerobic metabolism, which is not very efficient at things like ATP and all that stuff, building up lactic acid, and that's going to cause a higher A to B gradient. So these are your severe pneumothoraces, not your, hey, I got a 10% pneumothorax from a deep breath pneumothorax, right? These are your, hey, I got half of my chest has a pneumothorax going on. That might be where you might see that mixed acidosis. So think about this A to B gradient being increased with a mixed or combined acidosis, where it's a metabolic and respiratory acidosis. O2ER is going to be increased. Now, this is usually because both the DO2 is decreased, and if it's severe enough, it might also be because of the anaerobic metabolism going on as well. So, and then obviously your venous saturation will be low as well. So remember, if it's a pulmonary issue, it's a shunt-like process. All right, what does this do to our heart pressures? So all the right-sided heart pressures, now this is for a large pneumothorax, right? We're not talking about a 10% pneumo. We're not talking about just a barely 20% pneumo here. We're talking about like a 50% pneumo. We're talking large pneumothoraces here. So all your right-sided heart pressures, your CVP, your right atrial pressure, your mean pulmonary artery pressure, your right ventricular stroke work index, your pulmonary vascular resistance, these are all right-sided heart pressures. Okay? Those are all right-sided heart pressures. Because of the hypoxic vasoconstriction going on, all these will be elevated. Do you see that? Mean pulmonary artery pressure, right atrial pressure, central venous pressure, pulmonary vascular resistance, right ventricular stroke work index, all of those are increased because we have hypoxic pulmonary vasoconstriction. Now, what about my left-sided heart pressures? Now, this is where things are going to be different. When I'm looking at cardiac output, pulmonary capillary wedge pressure, stroke volume, systemic vascular resistance, left ventricular stroke work index, cardiac index, stroke volume index, right? So when I'm looking at all my right-sided heart pressures, they're going to be decreased because what's happening to my blood return to my heart? Remember, blood return to your heart is decreased. So, in a severe large pneumothorax. So all my left-sided heart pressures are going to be decreased. All my right-sided heart pressures are increased. This is different than any of the other things we have covered before. So please note, left-sided heart pressures are decreased. Right-sided heart pressures are increased. Hypoxic pulmonary vasoconstriction will always cause increased right-sided heart pressures. Oh heavens, did I make this backwards? I did. So left-sided pressures, and then this one up here should be right-sided pressures. Not perfect. Never claimed to be. Right-sided heart pressures. So when we're looking at this, hypoxic pulmonary vasoconstriction always causes the right-sided heart pressures to be increased. When we're looking at something that decreases venous return or crushing of the vessels, the left-sided heart pressures will be decreased because there's not enough blood, there's not enough volume getting there. All right, so you have a pneumothorax. What are some therapies, right? Depends how bad the collapse is. Like I said, 15 to 20% pneumothorax. Usually these are considered small. Mostly it's just limited activity, bed rest. Most of the time these will reabsorb themselves. Usually within 30 days, right? So just keep it easy for about a month. Don't keep going on doing your extreme sports or whatever it is, right? So these usually just resolve. Just make sure that they don't advance, right? Because they breathe deep, run fast, jump high, right? That could make it exacerbate and make it a bigger pneumothorax than it currently is. So most of the time these will just reabsorb themselves. Then when we have a pneumothorax greater than 20%, these are numbers I would hope you remember. A pneumothorax greater than 20% should be treated. Now, how do we treat it? Well, we can do a needle aspiration. Usually it's a large bore needle, like an 18 gauge or something like that. Second rib, midclavicular area. They could also do a chest tube to water seal, where gas can come back out but not back in. Obviously, we can give this patient oxygen therapy that'll help the right-sided heart pressures and help reduce the shunt-like process that's going on as well. Because remember, oxygen is a pulmonary vasodilator, so that should help with right-sided heart pressures, should help oxygen in their blood tissue. Also, oxygen in the pleural space, right? Remember, when you have a gas that you're breathing, that pleural space fills up with a bunch of gas. Some of that gas is nitrogen, some of it is oxygen, right? It's air, right, that you're breathing. Let's say we give this patient oxygen. Let's say we give them lots of oxygen. Then the nitrogen that's in the pleural space in theory could be replaced with oxygen. Well, which one do you think your body reabsorbs easier? Oxygen or nitrogen? Which one is actually a lighter gas according to the periodic table? So your body is going to be more likely to reabsorb oxygen. So if we replace this pleural space with more oxygen, then we're more likely to reabsorb that pneumothorax. Now, as far as the evidence goes, that's called the nitrogen washout theory, where if you give them high FiO2s for like 24, 48 hours, if you give them high FiO2s, you're replacing the nitrogen with oxygen in the pleural space and therefore helping resolve the pneumothorax more effectively. However, the evidence behind that is not very strong, and that's why you don't see the usually nitrogen washout in effect out there much anymore. So the evidence just doesn't currently support it as much. So oxygen therapy is going to be more for the hypoxemia than it is going to be for the nitrogen washout theory. So this is something that used to be pretty popular out there. However, the evidence doesn't support it being resolved any faster than just regular oxygen therapy, than without doing the hyperoxygen therapy. Lung expansion when it's treated, hyperinflation therapy. When it's treated, hyperinflation. The key part of that sentence is when it's treated, like after it's treated. Lung expansion therapy, because remember, we have a lot of residual atelectasis left over after the pneumothorax has been resolved, right? We need to reopen that lung tissue. Remember, 50 dynes per centimeter is a lot of force to reopen lung tissue. So this is where you do PEP, some sort of positive pressure, some sort of expansion, lung expansion therapy to help resolve that atelectasis that's left over after the pneumothorax has been treated. Not during the pneumothorax, after the pneumothorax has been treated. That's one of the things that we can look at. Now, if someone has recurrent pleural effusions or recurrent pneumothoraces, they can do what's called a pleurodesis, and that's pretty much adhesing the visceral and the parietal pleura together. So they're sort of either scarring up the tissue so it sticks together and they scar together, or they put this like powder in there that sort of sticks the visceral and parietal pleura together. That avoids excess fluid from being collected in the space and or air from being collected in that space as well. That's just a treatment or therapy for people that have recurrent issues. So something that you might see out there. All right, so diagnosis, and I wanted to put this in here. X-ray, of course, we've already gone over X-rays. Ultrasound. Now, this is an area that I want RTs to really expand into, and there's some RTs that are already doing this. So what does a pneumothorax look like on ultrasound? This is something we can do at the bedside. We don't have to wait for X-ray to come to the ICU to see if this person has, or the ER, to see if this person has a pneumothorax. We could almost see it right away with that bedside ultrasound. So the cool thing is we can put that on there, and we're looking for lung tissue to be sliding, right? And you see in the picture on the right the lung tissue sliding, and then down, if you look on the picture just below the wording here, you can see that you see the lung sort of sliding back and forth, and you see what looks like comets. I don't know if I can draw over it, but you see how there's light inflections that go on here. It's almost like the tail of a comet, right? Like if you're looking in the sky and you see a comet, you see a tail to it, right? You see that going on. That's a sign that there's lung tissue moving. Right, you can see it moving back and forth. So that's a good sign. That means the lungs are expanding and collapsing, like the lungs are moving up and down. There's not a pneumothorax. They're functioning as normal. If you don't see lungs sliding, if they're pretty stagnant, and I have that picture in the next slide, then that's a sign that there's a pneumothorax present, right? Because that means lung tissue's not moving. It's just collapsed and compressed, right? So this is what it would look like on an ultrasound. So the top right's an animation. Right, the bottom part is more likely what you would see. You'd look for that comet effect. You'd look for your landmarks, and we'll go over that in the subsequent slide. Of course, you can get a CAT scan in theory as well. Transillumination is more for neonates, and I have a picture, and we'll talk about that. And then your bedside evaluation, right? A hyperresonant percussion note, trachea deviated, all those things would play into effect here. Right, so this is that no lung sliding, right? Do you see that comet effect going on in this area? Well, I don't see it at all, right? You sort of see a little bit of just normal artifact movement, but you don't see the lungs sliding back and forth at all. That's a sign it is, no comet tail artifact. So you don't see that moving whatsoever, so that's a sign that that's the affected or pneumothorax side. So hopefully that helps you. If you guys are out in the ER, or you're in your rotation, your floor rotation, and somehow you see them, look for an ER, look for pneumothorax in the ER or ICU or something like that. That's what they're looking for, and hopefully you could sort of have that idea in your head. I know it's wishful thinking. Now, I won't test you on this. You should know that you could use an ultrasound to help you. I wish that I could make you guys responsible for this, but I am not that cruel sometimes. All right, so this is a transillumination. So this is something we use for babies to see if they have a pneumothorax at the bedside. So what we do, this is called a transilluminator. It's a very powerful flashlight. And if we put it onto their rib cage, right, and their whole chest wall lights up, if we see their whole chest wall light up, that's a sign that there's a bunch of free air in their rib cage, right? You see on this kid over on the right side, you see this little baby on the ventilator, and you just see that the whole left side of this kid's chest just is lit up. and that's a sign there's a lot of free air and there's a pneumothorax on that baby. So that's the sign of a pneumothorax with transillumination. Something we can use at the bedside. Is it as accurate as an x-ray? No, but it can tell us if there's a significant pneumothorax going on, and then we can look at probably either needle aspirating or something like that if we needed to with these little babies. It works for little babies. Adults, especially with significant body habitus adults, may not be effective. This is just a neonate thing, so transillumination for the NICU world is going to be one of your diagnostic tools that might help you as well. So normally, like if you were to just take a very powerful flashlight and put it up to your arm or to your leg or to your chest wall, it wouldn't light up the whole side, right? Because you don't have a lot of free air in there. And that's what you're seeing here, a lot of free air. And that's what you would see with transillumination. All right, review questions. These are for you to answer, not for me. So just have fun with it. What are the common lung alterations that occur with pneumothorax? Don't let it compress you. Little joke there. Please think about what are the common lung alterations that occur with the pneumothorax. What are causes of a pneumothorax? Not a question on here. What are some causes? Right, what kinds of pneumothoraxes are there? All right, this patient shows up at the bedside evaluation, or you get called to a room, patient with a pneumothorax. What would you see? Patient assessment. What would be their heart rate? What would be their breath sounds? What would be their percussion note? What would be their respiratory rate? What would be, like I said, their blood pressure, right? What are they going to look like? What would be their AP diameter be, especially if it was a one-way valve thing? So what are you going to look at with their trachea? Does it go with or against the affected side, right? These are all things that you'd want to look at. What about their x-ray? What are some common alterations you might see on their x-ray? Radiolucent, radiopaque, both? Mediastinal shift? No mediastinal shift? Atelectasis? No atelectasis? What would ABG look like on these patients if it was a very mild or small pneumothorax? What would their ABG look like if it was a very significant pneumothorax? Tell me about their oxygen delivery. Tell me about their VQ match. Is it shunt-like or dead space? Tell me what can happen with their metabolic rate if it's a severe pneumothorax. Patient has a resolved pneumothorax. You do a pulmonary function test on them after the pneumothorax has been resolved, right, down the road. What would it show with their volumes? What would it show with their flow rates? Would anything abnormal happen with the hemodynamics in a severe attention pneumo, right? What would happen with their hemodynamics? What would happen with their right-sided heart pressures? What would happen with their left-sided heart pressures? I'll repeat that again. What would happen with their right-sided heart pressures? What would happen with their left-sided heart pressures? What are some therapeutic interventions used to treat a pneumothorax?